Y'all, stop trying to memorize EKG strips. You're going to fail your Med-Surg exam if you're just looking at the pictures. Okay, so let me show you the secret to actually understanding them so you never get a rhythm question wrong again. But before we dive in, do me a huge favor. Hit the like button, save this video for your next study session, and tag a nursing student in the comments who's struggling with cardiac right now. We're in this together, y'all. So hook a sister up and engage. First things first is the foundation. Okay, you have to know the why. You have to know what a normal heart looks like at the electrical level. In normal sinus rhythm, that first little bump is the P wave. That's your atria contracting. The PR interval is just the electrical signals commute time from the top of the heart to the bottom. And that big spike, that's the QRS complex. That's the big squeeze where the ventricles pump blood out to the rest of the body. Okay? So now, once you understand how the heart should work, right? You can use my 6-step Med-Surg framework to break down any abnormal rhythm. So let's use atrial fibrillation as our first example. Number 1, the breakdown. So AFib is a supraventricular tachyarrhythmia. So basically, the SA node loses control and multiple irritable spots in the atria start firing like crazy. So instead of a clean contraction, the atria just quivers. So on your EKG strip, right, this means P waves are totally absent. They're replaced by messy, wavy lines called fibrillatory waves, right? Number two, risk factors. Who is at risk? So think advanced age, hypertension, heart failure, and valvular disease. But don't forget lifestyle triggers like obesity and sleep apnea. So if your patient has any of these in their chart, you need to be watching that monitor closely for a rhythm change. Okay? Number 3, clinical manifestations. So this is what you see at the bedside. AFib is irregular. Okay? So because the atria are just quivering, the patient loses their atrial kick and cardiac output drops. Okay? So your patient might say their heart feels like a fish flopping in their chest, right? So they might look dizzy, short of breath, or just tired because their body isn't getting enough oxygenated blood. Okay? So number 4 is diagnosis. We diagnose this primarily with a 12-lead EKG. So we're looking for that AFib signature, right? An irregular rhythm, no P waves, and a narrow QRS. We might also grab an echocardiogram to make sure there aren't any clots hiding in the atria before we try to fix the rhythm, right? Okay, so number 5. Number 5 is treatment and interventions. So our goals are simple: rate control and stroke prevention. So we use beta blockers or calcium channel blockers to slow that heart rate down so the heart can actually fill with blood. Okay, and because blood is pooling in those quivering atria, we have to use anticoagulants like heparin or warfarin to prevent a massive stroke, right? Number 6, patient teaching, right? So finally, you want to teach your patient. They need to know the signs of a stroke using the acronym Be Fast. Be fast, okay? Balance loss, eye changes, facial drooping, arm weakness, speech difficulty, and when to call, well, T for time, this is when to call the call 911. So if they're on blood thinners, teach them to use a soft toothbrush, an electrical razor, and teach them why they can't skip their follow-up blood work. Okay? So that's exactly how I study every single rhythm using the Med-Surg framework. No more guessing, just logic. Okay? And let me know if you want me to do ventricular tachycardia or, well, we already did heart failure. Let me know in the comments what you want me to do next, all right? Yeah, so that's it for this video. I'm going to always leave you with this. Never dim your light for anyone. Stay lit.